Thank you very much, dear chairpersons, and thank you very much, Dr. Khanna, for giving me an opportunity always to speak on this important topic. So last year at the same forum, we saw that the evidence-based prevention strategies for CIN were identification of at-risk patients with EGFR, discontinuation of nephrotoxic drugs, IV hydration, limiting the contrast volume, and choosing isoosmolar contrast media in the high-risk patients. Let us see what we have as an update this year. Well, this year there were 4 important publications on this topic. The first, the 2011 ACC-AHA focused update of the guidelines for UA and STEMI. Second, 2 independent meta-analysis by investigators McCullough et al. And Dong et al. And lastly, the German Medical Association guidelines for diabetic patients with CKD. The 2011 guidelines continued with the previous recommendation on estimation of creatinine clearance, but they deleted the recommendation on the choice of contrast medium, and they gave 2 new recommendations. One is for IV hydration, and second is for limiting the contrast volume by using the contrast volume to creatinine clearance ratio as a guide. Now let us see whether the other 3 bits of evidence follow the same line. McCullough et al. Published this meta-analysis in the Cardio-Renal Medicine Journal in October 2011, effects of intra-arterial versus intravenous isoosmolar contrast media on the risk of contrast-induced acute kidney injury. The premise of this meta-analysis was that CIN is a concern because it can prolong hospitalization, increase the risk of permanent kidney damage and death, and there is a strong biologic possibility that isoosmolar contrast medium might decrease the risk of CIN, because the hyperosmolar contrast media probably increase the risk of CIN by causing increased degree of intrarenal vasoconstriction, activating the tubulo-glomerular feedback and increasing the tubular hydrostatic pressure. So the objective was to compare the incidence of CIN in comparative studies of iodexonol, that is isoosmolar contrast medium versus LOCM, taking both the definition of CI-AKI and timing of serum creatinine determinations into account. Just to remind you, the low osmolar contrast media have a lower osmolarity than the previous first generation high osmolar ionic contrast media, but they actually are hyperosmolar to blood and to the isoosmolar contrast medium. So this meta-analysis, it included 25 studies. Patients on an average had a serum creatinine more than 1.6 and average GFR was less than 50, and studies up to December 2009 were included. There were 19 studies in the intra-arterial administration and 7 studies in the intravenous administration. The 2 definitions were serum creatinine of 0.5 milligram per deciliter or more, or 25% from the baseline. And the serum creatinine determination was a standardized time point of multiple or single serum creatinine measurement at fixed time points, or a non-standardized measurement, that is a single variable serum creatinine at any time between 48 to 120 hours. Now again, to remind you, if we want to capture the entire curve of the rise and fall of serum creatinine, then the better design is the standardized serum creatinine measurement, that is multiple fixed time point serum creatinine measurement, which will ensure that we make a valid comparison between the 2 contrast media serum creatinine elevations at individual time points. Whereas what happens when you have a non-standardized and a single serum creatinine measurement is that you might end up comparing the earlier time point serum creatinine elevations of one contrast medium with the late time point serum creatinine elevations with the other contrast medium. In other words, you would not be making a fair comparison. So let us look at the results of IV administration. There were a relatively small number of studies, and the included population of lower risk with younger patients, a narrower range of baseline serum creatinine levels, and a lower proportion of diabetic patients. In all, a lower risk population, and often had an exclusion criteria for serum creatinine elevation. And of course, to point out again that nearly 50% of the studies in the intravenous group had a non-standardized serum creatinine measurement, which was a bad study design, as compared to only 1 out of 19 studies in the intra-arterial group, which was a good study design. And therefore, it was not surprising that for IV administration, there was no difference in CI-AKI between iodexonol and LOCM. But let us look at the results for the intra-arterial administration. Iodexonol was associated with a lower risk of CIN compared to the low osmolar contrast media, statistically significant with the 0.5 milligram per deciliter rise of serum creatinine, and numerically significant with the 25% rise from the baseline of serum creatinine. The authors also made a compilation of 5 meta-analyses, and again similar results with the 0.5 milligram per deciliter rise of serum creatinine definition, The results strongly favor the isoosmolar contrast media, and with a 25% increase, there was a non-statistical favoring of isoosmolar contrast media. So the authors concluded that intra-arterial but not intravenous administration of isoosmolar contrast is associated with a significantly lower risk of CIN, and trials using intravenous had often a exclusion criteria for elevated serum creatinine, and as we saw, they were a poor design. Let us look at the other meta-analysis, Dong et al. Effect of administration route on the incidence of CIN. Contrast agents have dramatically increased. CIN prolongs hospitalization, higher rates of in-hospital, 1 year and 5 year mortality, and osmolality may have an impact on the likelihood and extent of CIN. Previous studies did not clarify between the difference between the two routes of administration, and therefore this study did a meta-analysis of the randomized clinical trials. They included 18 RCTs, including 3,129 patients. And again, the meta-analysis showed no significant decrease or difference in CI-AKI with iodexonal compared to LOCM. The Z-score for overall effect was 1.1, whereas in the intra-arterial administration, there was a significant difference in CIN between IOCM versus LOCM, and the Z-score for overall effect was 2.47. So they concluded that iodexonal may be a better choice for patients in the interventional cardiology setting. Let us look at the third bit of evidence, and that is the German Medical Association guidelines for kidney disease in adult diabetic patients. Their premises was that there are 10 million contrast examinations every year, and CIN is responsible for around 10% of all acute kidney failure cases, and results in extended hospital stay, and may result in compulsory dialysis in almost 13% of the patients, and a 5-fold increase in death rate. To date, there was no generally accepted recommendation for use of contrast procedures in renal failure patients, and they recommended that patients with diabetes mellitus with or without kidney disease should be treated at-risk patients. They recommend that all patients should be adequately hydrated, and the serum creatinine levels should be calculated within a week prior to the contrast examination and 24 to 72 hours after the administration of the contrast. As far as hydration is concerned, the recommendation was that it is the most important for nephroprotection and is sufficiently proven as a nephroprotective strategy. It was not clear from the literature which hydration protocol was optimal, but it was probably better if hydration is started from the evening before the examination. High contrast volume agents and repeated administration is a risk, and even the type of contrast agent matters, and this guideline made a very clear recommendation that isoosmolar contrast agents should be used for all the patients. There is no clear evidence for effectiveness of N-acetylcysteine, and the data is not sufficient to give a general recommendation for N-acetylcysteine, and dialysis did not result in a significant decrease. As far as concomitant medications are concerned, there was no evidence again to recommend stoppage of ACE inhibitors and ARBs. Metformin should be stopped on the day of treatment and not started again till it is clear that CIN has not occurred, and most writers advise that diuretics should be stopped 24 hours before and restarted only 24 hours after the examination. So to conclude, from these 4 bits of evidence in the past 12 months, the conclusion for CI-AKI prevention in 2012 is IV hydration remains the most important and evidence-based prophylactic measure. Limiting contrast volume and of course discontinuing nephrotoxic drugs is also very important. In the intra-arterial setting, there is enough evidence that isoosmolar contrast media has a lower risk of CIN than pooled low osmolar contrast media in high-risk patients, although the latest ACC-AHA guidelines shy away from making any recommendation. And all diabetics with or without CKD may deserve administration of isoosmolar contrast media as per the latest German Medical Association guidelines. Thank you very much, and I would be glad to take questions.
Thank you, Dr. Jani, for an excellent presentation. As you have emphasized upon the hydration, could you tell us, just for the benefit of the house, that what protocol you follow? How much hydration? What do you mean by adequate hydration, and exactly how much hydration to be given, and with what type of saline you want to recommend?
Again, this is a question which many researchers have tried to answer, and they have tried all sorts of comparisons. They have shown that oral hydration does not work. It has to be IV hydration. As far as IV hydration is concerned, what should be the nature of the agent used? They have shown that bicarbonate do not have any specific advantage over NaCl, and similarly, normal saline is better than half normal saline. So as far as the hydration protocol is concerned, the best hydration protocol proven so far is NaCl or any other crystallite, even soda bicarb will do, though it does not have a specific advantage. It should be started at the rate of 1 to 1.5 ml per kg per hour, nearly 6 hours before the administration of the contrast, and continue for at least 6 to 12 hours. And as per the latest German Medical Association guidelines, they recommend starting the IV hydration on the evening before the contrast administration.
The problem comes when a patient has severe LV dysfunction.
Right.
And you need to do a procedure.
Exactly. So I agree with you completely that these are the sticky clinical decisions, and it is for clinical decisions like this that we need to remain aware about the additional nephroprotective strategies like limiting the contrast volume and plus minus using N-acetylcysteine and using isosmolar contrast media.
See,
Two interventions needs a lot of contrast, and there is a concern about contrast in this nephropathy. Is there any role of prophylactic dialysis post-intervention to prevent it?
There is no evidence of prophylactic dialysis.
I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for the live cases coming up.
Dr. Jani,
Yeah.
this is very important issue,
Yeah.
what you have spoken. This is a third important cause for renal failure in the hospital.
Exactly.
So, what are the points which are not taken care of, as I am a nephrologist, I see many this type of cases, is one is the group. What we think, the high serum creatinine always 2, 2.5, we take it as a. Now,
Right.
the serum creatinine, which is borderline, GFR 60, 50, they are also very high risk.
Exactly.
So 1.2, 1.3, 1.4 creatinine, we should take it as we are managing a high risk patient.
In fact, you should always follow the ideal practice of converting that serum creatinine into eGFR or creatinine clearance and stratifying the risk of the patient based on these values rather than serum creatinine values.
And the second thing is, we should plan the cases if we can plan. For example, avoidance of the nephrotoxic drugs, for example, NSAIDs, for example, ACE inhibitors, if you can, for example, other drugs like aminoglycosides, cephalosporins,
Right.
they can reduce, a lot of toxicity because they are having additive effects.
Absolutely.
And apart from that, as you rightly said, normal saline is the seat anchor at the moment. N-acetylcysteine plus minus, other things are plus minus. So, and all diabetics, they should be taken care of as a high risk. Whatever the GFR is, high or low.
Right.
So if we take care of this, we can reduce the morbidity and mortality by 50%.
Very true.
If we take this.
Very
so
true.
these are the, important things.
Thank you very much,
Thank you,
Mr. Chairman.
Thank you.
One point more,
thank you,
that a
Dr.
creatinine of 1.5 should not be taken lightly.
Yeah.
We must calculate the GFR
Calculate the
and
GFR.
then rely upon it.
Absolutely.
We'll straight